Before we talk about what palliative care is, let's acknowledge some of these misconceptions and myths. It equals end-of-life care or means the patient is dying. Many only associate palliative care with hospice. While an important component, hospice and end-of-life care is a small component of the total care provided. My goal is not to get the DNR or convince a family to pursue a comfort measures only approach to care. Many patients who benefit from palliative care live for months or even many years. Some are reluctant to involve palliative care because they worry it means there's no hope or that we're giving up. Palliative care is appropriate for many patients receiving cure-directive treatments when cure is possible and when there's a great deal of uncertainty. We really help families explore or at times redefine what hope means to them. A big myth is that it means there's nothing left to do or that we're withdrawing care. There is always something to do, and care is continued even if the focus is different than what it previously was. Some feel that death is a failure. Our responsibility, though, is to really understand the overall condition and the likelihood of whether interventions will result in a positive outcome. A peaceful death and a shortened life surrounded by love is meaningful and really can be a success. Some may think withdrawing or withholding life-sustaining interventions is unethical. When making decisions, it's really important to consider suffering and quality of life. If treatments are causing more harm than good, non-initiation or redirection of care can be justified. Another misconception is that palliative care is the same for all age groups. Children, and especially neonates, have different disease processes, symptoms, and communities that really lead to different medical and psychosocial considerations to navigate. The unique care requires age-specific expertise and training. Now that I've highlighted some of the misconceptions, I'll talk about what palliative care is. The concept of palliative care has been acknowledged in medicine really for centuries now. The term palliate was initially interpreted as to alleviate without the intent of curing. Over the years, though, the definition and scope of palliative care has really evolved. The field first gained great momentum in adult patients during the 1960s with the realization that modern medicine doesn't address all of the issues patients with serious and life-limiting illnesses experience. The World Health Organization defines palliative care as an approach that improves the quality of life of patients, adult and children, and their families who are facing problems associated with life-threatening illness. It prevents and relieves suffering through the early identification, impeccable assessment and treatment of pain or other problems, whether physical, psychosocial, or spiritual. By the late 1970s, pediatrics began incorporating several concepts of care from the adult hospice with a focus really on suffering in children who were dying. In 1979, a paper highlighted the importance of a multidisciplinary team really meeting the emotional, financial, physical needs of families of children with cancer. And this was really the first paper that was published discussing this. Around the same time, the pediatrician's manual included a letter from a 13-year-old boy who was dying. And in that textbook, he wrote, "The dying person is not yet seen as a person. He is a symbol of what every human fears. Don't run away. Wait, all I want to know is that there will be someone to hold my hand when I need it. I am afraid." By 1983, there was a growing awareness of the importance of the principles of palliative care for all children with serious illness, not only those who were dying. And in the Oxford Textbook for Palliative Medicine, one of the key textbooks in palliative care, included a section on pediatric palliative care for the first time in 1996, really affirming that it was indeed a legitimate field of study related to but different from adult palliative care. While there was this increasing recognition and publications, management and practice changes really took decades to enact. In 2000, the AAP issued its first policy statement on pediatric palliative and end-of-life care, really calling for the development of clinical policies and minimal standards that promote the welfare of infants and children living with threatening or terminal conditions and their families, with the goal of really providing equitable and effective support for curative, life-prolonging, and palliative care. Shortly afterwards, the Institute of Medicine recommended institutional guidelines for care. And by about 2008, there was official board certification through the American Board of Pediatrics in Hospice and Palliative Medicine. Around the same time, the AAP developed a provisional section for hospice and palliative medicine, which really became permanent 2 years later. Throughout this time and the decade since then, research has really highlighted where the needs are, the experiences of patients and families in different structures to provide this important care. Specific to neonatal-perinatal palliative care, in the 1970s, providers published an article really describing the difficulties of withholding therapies in the special care nursery. In this truly landmark article, they described setting limits on extending life for 43 neonates after considering the prognosis, saying in the article, "For this child, don't you think it's time to turn off your curiosity so you can turn on your kindness?" They also in the article noted the awesome finality of these decisions, combined with the potential for error in prognosis, made the choice agonizing both for the families and the healthcare professionals. They went on to say in the article, though, that nevertheless, the issue had to be faced, for not to decide is an arbitrary and potentially devastating decision of default. Several years later, that notion of adapting concepts from the adult hospice model to address issues related to caring for the dying neonate were described in various settings and papers that came up over the subsequent decades. It wasn't until 1997, though, that the first perinatal hospice team was described. A team of 2 OBs, an MFM, a neonatologist, and a nurse really described perinatal hospice with the goal of providing antepartum counseling, preparation, and support through the pregnancy and the infant's life. Since then, there's been exponential growth. If you go onto the website perinatalhospice.org, it currently lists over 260 programs in 43 states. However, the types of diagnoses seen, care models, training of members, and continuity of care really vary significantly between all of the programs. This quote from Brian Carter really gets at what the heart of what neonatal perinatal palliative care is. He highlighted that survival is not the only measure of success, and perhaps more importantly, it includes helping families find meaning in their babies' lives. Providers must consider suffering of the baby and their families and find ways to help support them in their goals. Neonatal perinatal palliative care has really grown out of the field of hospice and palliative medicine with the goal of caring for and supporting families with a concerning, life-limiting, or life-threatening fetal or neonatal diagnosis. When such a diagnosis is made, the pregnancy and birth narrative has really been broken for the family. The goal is to offer comprehensive interdisciplinary care during the remainder of the pregnancy and afterwards, help parents process the information, consider the potential care paths, and really parent their baby. For each family, this care is unique and is continued irrespective of the disease trajectory, treatment options chosen, or transitions in care settings. In the midst of an intensive care mindset, my goal is to provide total care and support to the entire family. The team can really assist in communication, support families in complex medical decision-making, promote value-driven medical decisions, and ensure there is continuity in care. In addition to helping the family understand the diagnosis and medical management, we really provide opportunities for birth planning and memory making. The focus is on quality of life and comfort, irrespective of the medical management goals. A big part of this, which is important in the NICU, is pain and symptom management. End-of-life care is one component of this total care. Because the perinatal and neonatal period is unique, it really requires a unique approach to palliative care. This is usually a time of joy, anticipation of life, and hope for making many memories growing as a family. When a serious diagnosis is made, every milestone and stage of the pregnancy, birth, life, and death are different from what was hoped for or anticipated. As this figure illustrates, the care is really a culmination of principles from intensive care, ethics, and palliative care. It can start at different time points or happen over various stages, usually broken down to prenatal, delivery, and postnatal care. It can also occur in various settings, from the NICU to the newborn nursery to home, depending on the situations and goals. Regardless of the timing and location, though, families and babies deserve and need comprehensive care and complete support from the team. There are multiple paradigms for palliative care that this figure illustrates. The first model represents the series approach, an early model, which some still equate with palliative care. Once there's a terminal diagnosis, curative therapies are continued until they are seen as futile. After that, palliation and comfort measures are offered until the time of death, and then bereavement support is given. As the field has evolved, many have adapted this parallel model in which palliative care is introduced early in combination with curative therapies, and as the disease trajectory changes, the care model changes with it. The final model, C, the integrative model, is really most conducive to neonatal-perinatal palliative care. When a serious or life-limiting diagnosis is made, the concepts of palliation are introduced along with curative therapies, and the focus and goals change with the disease trajectory. Recognizing that the family is experiencing loss at the time of diagnosis, bereavement and grief support are offered from the beginning through that entire illness course and after death. At any one time, there really is a balance between curing, healing, and bereavement, or being with and doing two. It's important to understand when it may be appropriate to consider foregoing or withdrawing life-sustaining medical therapies. In 2023, the AAP affirmed their policy statement to guide pediatric providers. In situations where the burdens might outweigh the benefits, shared decision-making should be used with deferral to parental preference the majority of the time. These situations can include the periviable period, multi-organ failure, and severe congenital anomalies. They note that artificial nutrition and hydration are medical therapies and may be withheld or withdrawn when they provide no net benefit. They also note the importance of understanding the legislative regulations that may vary by region. From a legal standpoint, the 1984 amendment to the Child Abuse Prevention Treatment Act really calls for the continuation of medical therapies unless an infant is chronically and irreversibly comatose, or the provisions of such treatments would merely prolong dying, be ineffective in ameliorating all of the life-threatening conditions, be virtually futile in terms of survival, or in that context, the treatments would be inhumane. Physician decisions for neonatal care cannot be based on quality of life or other abstract concepts, they say. The enforcement really hinges upon the threat of removal of federal funding from public hospitals. Initially, because of concerns about the implications and the language used for clinical practice, providers increasingly pursued invasive interventions without deferral to parental wishes. Over time, though, with the support of the medical governing bodies, providers felt comfortable discussing all appropriate treatment options, including foregoing life-sustaining medical interventions. The framework that the AAP outlined on deferral to parental wishes is similar to the impermissible, permissible, obligatory framework for critical decision-making for neonates. Based on the anticipated harm and benefit, a treatment can be classified as ethically impermissible, permissible, or obligatory. For providers, though, the challenging part is really deciding where a treatment should be located on that spectrum. This is determined by the prognosis with and without treatment, the feasibility of providing the treatment, and the consideration of all relevant rights and obligations. Ethically permissible treatments should be explained so parents can choose from the options. Within that zone, treatments may be inadvisable or advisable, but parents can accept or forego those recommendations. It's often difficult to predict a neonate's course or future complications. This uncertainty brings many questions and discussions about the neonate's response to intensive care, complications encountered, and what actions are really in the neonate's best interest, really necessitating open communication, transparency and prognostication, and attention to empathy. Why are we discussing this today? As intensivists, our goal is typically to save lives, and many of our patients have what families and providers would consider a good outcome. While this is true, each year in the United States, there are over 1 million fetal deaths, 26,000 stillbirths, and greater than 19,000 neonatal deaths. Over 100,000 individuals have a pregnancy complicated by a fetus with severe abnormalities or a complex diagnosis, and over 500,000 neonates are born prematurely or with severe congenital malformations. All this to say, providers who care for pregnant individuals or neonates will be tasked with caring for a patient with a concerning, life-limiting, life-threatening, or complex chronic diagnosis multiple times throughout their career. Which babies and families benefit from neonatal perinatal palliative care? An argument could be made that any who are in the NICU do. When we think about those that would benefit the most, we think about ones with a concerning, life-limiting, or life-threatening fetal or neonatal diagnosis. I think of it as diagnoses or situations where the chance of survival without significant morbidity that could impact quality of life is low. This slide is not meant to be an exhaustive list of diagnoses. It's quite broad and includes the periviable patient, multiple genetic diagnoses, and serious diagnoses involving various organ systems. For many of these diagnoses, there's a range of prognosis, treatment options, and care paths. While some receive comfort measures after birth, many are cared for in the NICU and even discharged home. Individuals and families may receive a serious diagnosis that leads them to consider the different ethically and medically appropriate care options early in pregnancy, shortly before delivery, and after the baby is born. Each time point is unique. Advances in prenatal screening and diagnostic technologies have really allowed for the earlier, more frequent identification of these diagnoses. Fetal echo, or MRI, can help to characterize anatomic differences. Expanded genetic testing may allow for greater prognostic information. With multiple potential care options, an increased number of families are really seeking support, anticipatory guidance, and counseling after a complex fetal diagnosis. While learning the diagnosis earlier allows families time to make informed decisions and plan for the remainder of the pregnancy and, when appropriate, birth and neonatal care, it can also lead to more options and uncertainty as to the prognosis and most appropriate care plan. This is in the context of a family processing the information while they are grieving. The involvement of a palliative care team or the paradigms of palliative care allows for opportunities to explore goals of care and plan for comprehensive, value-driven medical care. The unexpected news of a complex or potentially life-limiting fetal diagnosis can bring about a constellation of reactions, emotions, and experiences that may be foreign to families and providers. This response is really unique to each family and their pregnancy journey. For families continuing the pregnancy, it's not unusual for them to describe a duality in their parental experience. They are preparing to welcome a new life while simultaneously grieving the loss of the baby they were expecting and sometimes the baby itself. There are many factors that influence a parental response to a potentially life-limiting diagnosis or uncertain prognosis. The experience with receiving the information, how the news was discussed with them, an individual or couple's faith or value structure, perceptions or tolerance of uncertainty, fears of decisional regret, and anticipatory grief. Listening to a family share their pregnancy journey grants perinatal providers a foundation from which they can explore values and support families in planning. The decisions they may be navigating include abortion, comfort measures, and intensive neonatal care. Some really view the option of perinatal comfort care as an extension of reproductive choices, and until recently, it wasn't something that was discussed or routinely offered to individuals and families. 20 to 40% of individuals continue a pregnancy after a severe fetal diagnosis. The reasons are variable and unique to each dyad. Some are not offered or cannot obtain an abortion. For those who have a choice, many express a connection to their baby and want time with their baby. Those who elect for comfort measures feel they're making a decision to really protect their child and want to focus on spending time as a family and making sure their baby is comfortable. Some who elect for intensive care wish to give their child a chance, have hope for a good outcome, wish for a miracle, or view the prognosis with interventions as an acceptable quality of life. Few express skepticism or doubt in the diagnosis or prognosis. Irrespective of that treatment path, afterwards, the majority have no regrets and find meaning in the time they have and in their child's life. There are times when the diagnosis is made shortly before delivery. In this setting, communication is often rushed and chaotic, and decisions are incomplete and fragmented. There isn't time to provide comprehensive information or to completely assess parental understanding, values, and goals. In this setting, we really provide assurance that it isn't the pregnant individual's fault, privacy, and space to process the information while they celebrate and welcome their baby, and assurance that we will continue to support them as they are receiving and processing information. It remains imperative to provide accurate information and an environment conducive to expressing their emotions. They need to know that the care path may shift and evolve as they learn more about the diagnosis and prognosis, and the team will support them and the evolving decisions and plans that are being made. When the diagnosis is made after delivery, families are often in a state of shock. Most assume that if a pregnancy and delivery are uncomplicated, their baby will be healthy. For them, it is a sudden loss of that healthy baby they were holding moments before they received the news. There was an abrupt change in the course, discussions, and focus. In this setting, it's important to continue to promote bonding and to ease the guilt burden. We must help families integrate the information, redefine what hope means to them, help them form goals, and make decisions very different from the ones they were previously making for a baby they thought was healthy, and to ease suffering. The delivery of the news and the discussions that follow really shape the experience with the care team, their memories with their child, and their subsequent bereavement. Our families are in an incredibly difficult and impossible situation. They are hearing and processing the loss of the newborn experience they were expecting. At the same time, they have to begin to understand the likely diagnosis, prognosis, and treatment options. When there is uncertainty, either about morbidity or mortality, it complicates the picture and leads to more questions. While navigating this, they hope for time and are trying to find ways to really connect with their baby, the care team, their support system, and really to begin to understand that parenting will look different than they had hoped. In order to provide optimal care, it's important to really understand the experiences of parents and providers. Families report variable experiences. In a study where bereaved parents use adjectives to describe providers, 67% commented negatively on interactions with staff. Some adjectives they used to describe providers were distant, cold, harsh, unfeeling, absent, and abrupt. They desire availability and attentiveness from the care team, but some felt ignored or that they had to ask to speak with the providers. Reflections on a negative interaction included recalling a provider saying, "You need a reality check, he's going to die," and then quickly walking away. These interactions negated the multiple positive experiences they had and remained as vivid reminders of their last moments with their child. A single event, such as insensitive or rushed delivery of news, perceived disregard for parental judgment about a child's care, inflexibility, and poor communication of information can cause parents profound and lasting emotional distress. While the timing of the news likely alters the experience and requires slightly different approaches and focus, the total care provided remains the same. Families desire confidence in the treatment team. They want familiarity, honesty, and compassion. They hope for timely, clear information. Contradictory information or not giving complete information leaves families feeling like we're beating around the bush or keeping them in the blind. They want availability of the care team and to be heard. This means really allowing them an opportunity to talk and to be part of the conversation. They want to have an active role in decision-making with our support and recommendations. It's a partnership where we are the experts in the medical information and they are the experts on their baby. They need time for the information to set in and time with their baby. Families really stress the importance of memory making and bereavement follow-up. For the most part, they innately assume we have the medical knowledge and hope we are compassionate and understanding in our approach to care. They expect we know what we're doing and they expect that we value their perspective. They really deserve that. It's also important to consider the provider's perspective. A national survey of neonatologists showed that 58% have palliative care teams and 72% have staff support groups or bereavement services. Palliative care was deemed important, needed, and beneficial for families and staff. Most providers feel comfortable providing this care. They say barriers include lack of education, emotional difficulties, and disagreement amongst staff. Many really acknowledge challenge in determining the timing of involving palliative care and that the uncertainty of prognostication adds to this. Palliative care teams or staff bereavement groups are predictive of willingness to initiate palliative care and more positive views or experiences. Consistent themes include the need for modalities for improving end-of-life care, inconsistency of the delivery among providers, and the need for education. Taking care of neonates with a serious illness is challenging. We want to save lives and make babies better and are trained to offer intensive and invasive therapies with the goal of saving lives. It can be difficult to shift our goals of care in the face of a life-limiting illness. It's emotionally, personally taxing and doesn't feel good to talk about the possibility of a patient dying or living with severe morbidities. There's fear of being blamed, not knowing the answers, or of death itself. There's a fear of saying the wrong thing and upsetting or hurting them. There can be an inherent hope for miracles and expectation of positive responses to medical technology. We all remember that one patient who proved us wrong. Prognosticating and knowing the limits of current medical technology is incredibly challenging. More and more, we seem to have one more intervention or therapy we can offer or try, and survival outcomes are rapidly changing. We can also get caught up in that treat and cure philosophy or think we have to wait until we've exhausted all medical options before we involve palliative care. In addition, there are the physical challenges and time constraints of the unit that make having difficult conversations, providing comprehensive care, and navigating goals of care challenging. Earlier, I gave a list of diagnoses that potentially benefit from the involvement of palliative care. Globally, you can break it down into conditions where curative treatment is possible but may fail, conditions requiring long-term treatment to slow the progression, and premature death is still inevitable, progressive conditions with expectation of early death irrespective of the treatments offered, or conditions involving severe disability and medical complexity. This graphic has possible triggers for when to consult palliative care. Triggers can really be broken down into reasons related to the disease, treatments, symptoms, or psychosocial reasons. If the diagnosis has a high mortality, the patient is not responding to therapies, has multi-organ failure, or is expected to survive with dependence on medical technology, a palliative care consult can be beneficial. Similarly, if the hospitalization is prolonged, or there's not significant improvement with therapies, it may be helpful for the family and team. If there are difficult to control symptoms, communication challenges, complex medical decisions to make, goals of care to navigate, or the family has previous experiences with a critically ill child, palliative care can be invaluable. Once you decide to consult palliative care or involve the paradigms of palliative care, how do you discuss it with the family? Palliative care should not be introduced as, "I'm sorry, there's nothing more we can do for your child, let's contact palliative care." It should be presented as a part of the medical team and a specialty that offers a layer of expertise and support for children with serious diagnoses and their families. The focus is on relieving suffering, improving quality of life, while helping families adapt and function, offering guidance with complex goals of care decisions, and coordinating care between different settings. I treat it like any other consult. Rather than asking for permission, I explain to the family why I'm involving in the team and how they can be helpful. I think it's important to remember that if a family has heard of palliative care, it's most often in the context of hospice or end-of-life care. It's important to explain to them the total care that is provided, how it extends beyond hospice care, and how you and the family will collaborate with them. It's important providers in the NICU have an understanding of some of the key components of palliative care and incorporate those foundations into their practice. Through the remainder of this series, you will receive education on important aspects of neonatal palliative care. Today, I'll highlight some key components and provide a brief overview and considerations for practices related to communication, navigating goals of care, and end-of-life care and symptom management. While we often have complex conversations, it's important to remember that it's not just these conversations that are important. Our daily dialogues and interactions are equally important. They help build trust, rapport, and the foundation for more serious conversations. If the first time we interact with a family is around serious news or making difficult decisions, there's a high likelihood that interaction will go poorly. Every conversation and interaction you have with a family is important and meaningful. What does great communication look like? Think about things that you do well. Using language the family can understand, not talking above them or using medical jargon. Paying close attention to nonverbal cues you're sending and making sure they suggest that you are present and engaging in that open conversation. Talking less, listening more. Handling the awkward moments and not shying away from emotions or difficult conversations. embracing uncertainty with sensitivity, and appreciating how difficult this is for families, leaving room for hope without giving false hope, remaining present even in the difficult moments, allowing time and space for reflection and processing. While there are advanced communication skills, and you'll talk about some of them in next month's session, these are some basic concepts to help guide conversations. This slide includes some phrases to avoid. They're statements that were made to families. Likely, providers intended them to be comforting or helpful, but they are not. Don't assume that a family believes in God, or that if they do, that saying it's God's will comfort them. Don't assume you know how a family feels or what you would do in their situation. Telling them to count their blessings is not helpful. They are experiencing something no parent should have to. Any emotion they are feeling is valid. It's also important to avoid using terms such as stable unless a baby truly is, or talking about withdrawing support. Support and care are always continued, even if there is a shift in what that looks like. These are several of my babies, 2 of whom went home with a comfort measures approach to care and 2 who underwent multiple surgeries and a prolonged NICU stay to save their lives. When having conversations and navigating goals of care, it's helpful to remember several things. Some families experience a lifetime of tragedy and suffering with the prolongation of life. At the same time, many imperfect lives have significant value. This is why it's really important to understand the values, goals, hopes, fears families have, and really engage them in that decision-making process. It's also important to remember that while the timing and details can be different, very few infants die with comfort measures who otherwise could have survived long-term. Knowing these things makes me very comfortable living in that gray area and putting my personal views aside when talking with families and helping families navigate complex decisions. It's important to understand the process of decision-making. The first phase is really to identify the decision that needs to be made. That will be different depending on when the diagnosis is made and the clinical circumstances. The next is to really conduct a risk-benefit analysis to weigh objective medical information and subjective factors. It's only after that that a parent can make a decision. Many factors influence the decisions that are made and go into that risk-benefit analysis. These factors include personal attributes such as parental age and medical history, gestation at diagnosis, the context of the pregnancy, if it was planned or they had a long journey to become pregnant, past experiences with the medical field, and socioeconomic status. Personal views, including religious beliefs, cultural values, tolerance of uncertainty, views of quality of life, and beliefs about the various care options play a significant role. There's also the information itself and how it is conveyed to families, the severity of the anomalies, expected prognosis, treatment options available, the influences of families and friends matter. And then there are those structural influences, including whether an individual has access to all of the options for various reasons. Decisions are made based on multiple important factors beyond the medical facts or information you convey to the family. When weighing the risks and benefits of a treatment path, parents consider diagnostic and prognostic certainty, likelihood of a good outcome, and avoidance of suffering and regret. It's important to discuss the certainty of the diagnosis and prognosis and the meaning of that prognosis to the family so that they can weigh the risks and benefits of each care option appropriately. Prognosticating is challenging. In reality, there usually is a spectrum of outcomes. Providers, though, often use terms such as lethal or portray the prognosis for various diagnoses as grim instead of clearly articulating that spectrum. Families want to know the spectrum of possible outcomes and how different types of care can impact them. Hearing that range allows them to understand what might be possible and to prepare. Quality of life is a very personal determination. Families do not want personal opinions or biases to impact the information they're receiving. It can damage that therapeutic relationship and leave them feeling guilty for the decisions they've made or unsure of how to make the best decisions moving forward. After the diagnosis and relative certainty of prognosis have been understood and discussed, we can begin to have in-depth discussions and navigate goals of care, something that I did with each of these families. We've all been there. We've counseled a family about a test, treatment, or diagnosis. They can engage in the conversation and understand what we've conveyed to them and might even be able to repeat it back to us. At the same time, We're not sure that they know what the information truly means in the context of the situation or have processed and incorporated it into their decision-making framework. What we're really talking about is the difference between knowing the facts or information and deriving meaning from it. It often takes time to process information, especially about a potentially life-limiting fetal or neonatal diagnosis and related to individual circumstances. We cannot assume that because a family has been given and understands the information, that they have incorporated it into their views, values, and framework in order to make truly informed decisions. In order to help families derive meaning from the information, we must facilitate comprehensive conversations. These conversations generally begin with exploring values, hopes, and fears and lead to the creation of a care plan that honors these views and wishes. The goal is not simply to deliver information or direct decisions in care. The intent is really to engage in a dialogue that promotes autonomy and informed decision-making. The focus should be on the patient, their values, their goals, their new unique journey. Knowing this will make it easier for us to provide information that the family can derive meaning from and make truly informed decisions with. What we're really talking about is that shared decision-making approach to care. It's our job to engage in a partnership to really better understand how, in the context of their specific situation and goals or values, the medical information is important. Based on that, we can arrive at a decision about the most appropriate plan of care that builds trust, minimizes burden, promotes the best patient outcomes, and incorporates parental preferences. Parents really rely on us, the providers, to encourage them to express their hopes, fears, and goals. Only then can providers and parents really collaborate to make decisions and plans really balance in autonomy and parental authority with medical recommendations and prognosis. A key component of the shared decision-making process in navigating goals of care is the development of the perinatal palliative care birth plan. It really expands beyond preferences for logistics surrounding delivery to include value-driven requests for care. In addition, it can give families a sense of control during a challenging time, an opportunity to honor their child's life and actively parent. The therapeutic value is tremendous. It also lets providers know their expectations and understanding. Important components are listed on this slide. They include information for the care team, wishes for labor and delivery, wishes for the medical care of the baby, wishes for memory making and support, and plans for if the baby survives or dies. This is really a time to also get creative and help families, irrespective of their medical goals, explore ways to celebrate their baby in the time that they have with them. It includes details such as desires for resuscitation, location for the care of the child, keepsakes, and when appropriate, family-centered neonatal end-of-life care. The medical information included really helps the team understand what the family has been told to expect as far as morbidity, mortality, and anticipated medical challenges. It's important for us to expand on any uncertainty and things that are important to the family if their goals are conflicting or cannot be met. With this plan, really the OBs, nurses, pediatricians, neonatologists know the goals prior to delivery and can discuss a plan that will achieve as many of those goals as possible. While end-of-life care is a small component of the care provided, it's important. If a family elects for comfort measures right after delivery, months after being in the hospital, or the baby is dying despite escalating medical support, it's important to ensure the family has support, privacy, and are surrounded by familiar providers. Refer to the baby by name and be compassionate. Conversation should be open and honest. Do they need additional information or tests? Do they need directions and guidance in these decisions? If a family is interested in organ donation, it's important that they know how that will change their end-of-life experience. Ask about the specific needs that the family may have. Prepare them for what the death will look like, the physical changes they will see, and avoid a specific time frame. Plan for the timing of the redirection, the location, and options. Who should be there? In the midst of the grief, help them think of beautiful memories to make and ways to really spend time with their baby. Are there rituals that are important for them to honor? Remember to support parents also in talking to siblings and other family members. You will get an entire session later in the year on end-of-life symptom management, but in general, symptoms commonly seen at the end of life include respiratory distress, dyspnea, pain, agitation, and secretions. In general, Optimize non-pharmacological interventions early, as they can be very effective. When pharmacological treatment is necessary, medication choices and doses may need to be adjusted based on prior exposure. For example, if a neonate is already on an opioid infusion, the dose may need to be increased. Medication should be introduced and titrated in a stepwise approach. For dyspnea, positioning and opioids are most effective. The opioids don't eliminate the work of breathing, but they make it so that the baby can't sense that it's getting harder to breathe. For pain, acetaminophen and opioids are very helpful. And for agitation, ensuring a calm environment with familiar people is so important. Swaddle on the baby and encourage skin to skin. Benzodiazepines, alpha-2 agonists, and gabapentin can be helpful when pharmacological interventions are needed. For secretions, positioning can be helpful. The anticholinergics may decrease or thicken the amount of secretions, but they don't actually help the baby handle them or eliminate that rattling noise. Be familiar with the expected symptoms and management approaches so that you can proactively develop a plan and give the baby as peaceful of a death as possible. What about when the baby is dying or afterwards? It's important to clearly and compassionately tell the family that their baby has died. Use the D word. You'll also need to ask about autopsy, if not done beforehand, and determine where they want the body to go. After pronouncing, you'll have to notify the organ procurement organization if not done previously, write a death note, and fill out a death certificate. The family can stay with the body as long as they want to, and if the mother has been providing breast milk, it's really important to address milk suppression or donation. When they leave the hospital, give them a stuffed animal or something to hold so that they don't have to leave empty-handed. This is really a unique type of bereavement and grief. Parents and family members are forever changed by the death of the baby, yet are often expected to be back to normal within a few months, and many people in their social network never met the baby. Ensure you provide the entire family with support resources. Families appreciate follow-up with the care team, meetings, cards, phone calls, and invitations to memorial events. I think it's also important to recognize the impact on staff. In the NICU, we are exposed to traumatic events on a daily basis. Provide opportunities for bereaving, debriefing, emotional support to colleagues, encourage bereavement events, and availability of psychosocial support. I covered a lot in a short period of time, so let's take a step back and look at that neonatal-perinatal palliative care journey map. While I broke the timing of the news into 3 separate timeframes, it's not always that distinct. In general, it's important to remember that many fetal anomalies are not identified until the 18 to 22-week anatomy scan, and about 25% are not identified until the 3rd trimester. While grieving, the family often has a limited window to gather more information about what the anomaly means for the pregnancy and to make decisions about abortion, fetal intervention when appropriate, or the care path that best aligns with their views. Mapped out on this slide, they're meeting with multiple subspecialists in green to discuss the prognosis and care paths in blue at a time when they really need trust with their care team. The obstetrician, who they developed a strong relationship with, may or may not continue to follow them. When a family continues the pregnancy, there are multiple visits with different providers in different hospital systems. If they elect for comfort measures, it'll be important that everyone is aware of their goals and what that care will look like. It's important to remember that the initial conversations and the medical decisions may trigger a cascade of events that lead to many more complex decisions. When families elect for invasive interventions, we will be providing care for a medically complex patient. We engage in ongoing conversations about the goals of care in purple and treatment paths as they may shift over time. With the multiple complications, challenges, and invasive interventions, there will be many decision points. Having a consistent care team, the palliative care team, who over time knows the family and their journey, facilitates trust, open conversations, and mutual understandings as they're navigating these complex decisions. After delivery, the scope of palliative care extends well beyond ensuring comfort at the end of life. Palliative care can be introduced at any time during the illness course. For conditions associated with a poor prognosis or known to carry a significant symptom burden, it can be introduced immediately. Families should not have to choose between treatments and quality of life. Early involvement can improve symptom management, promote goals of care discussion, and increase the use of services in the community. Some patients graduate from the NICU and continue to improve, ultimately being discharged from the palliative care team. Others are discharged from the NICU and continue to have a high degree of medical complexity, and the palliative care team supports them over time. Others die in the NICU or shortly afterwards, and the care can be extended beyond the child's life to caregivers during bereavement. Palliative care really allows for continual support, consistency, and counseling through all phases in care. This continuity facilitates seamless transitions in care and a unique opportunity to walk the journey with the family. Immediately after diagnosis, families are grieving. They often need time to process the information and may need more information before making decisions. As the pregnancy continues, they're beginning to really incorporate the medical information into their decision-making framework. Our job is really to ensure that all providers are aware of the information, where they are in their journey, and their goals so that unified care is provided. It's important that we help the families understand what the medical information means in the context of their values and views. Remember that when it comes to a fetus or baby, the parents may not have thought about quality of life or advanced care planning for themselves, let alone for their baby. It's also important that we help them celebrate moments during the pregnancy and make beautiful memories. Even after delivery, families may need more information to determine the most appropriate care path for their baby. We should provide them with clear information and support a shared decision-making approach to care. This includes facilitating comprehensive conversations, engaging in navigating how the medical information is important in the context of the decisions that need to be made, or reshaping expectations for the future, and understanding how they're making decisions. The palliative care team is really a consistent presence and can help to anticipate decision points, ensure the family has the information they need, and help team members and families realize that those goals may evolve and change over time. We really support families from the time of diagnosis throughout the remainder of the pregnancy and neonatal course and beyond. I think this quote from former New York Senator Javits in reflection of his battle with ALS sums up the importance of the work we do. It really comes down to realism, dignity, and love. When a family is faced with a complex or potentially life-limiting fetal or neonatal diagnosis, providers are really tasked with supporting the family and helping them navigate goals of care, often in the face of uncertainty. This can be incredibly challenging, fraught with emotion, and incredibly rewarding. The paradigms of palliative care are important in providing optimal care. Our job is really to better understand, irrespective of our personal opinions, their views of quality of life, and help them develop a plan that supports their wishes and views. The difficult decisions that are being made, the care that is being provided, and the experience of the families has impacts not only on their time with their baby, but the time afterwards. Irrespective of those medical management goals, palliative care has a role in the NICU, focuses on comfort and quality of life, and allows for value-driven medical care, collaboration, and seamless transitions across phases of care. And to finish it off, these are three of my patients. The first is a girl who had a complex course, including in utero interventions, an ostomy placed in her first days of life, and peritoneal dialysis. She received her first kidney transplant and is doing well. The second is of a beautiful girl whose families took her home with a comfort measures approach to care, where she was surrounded by love her entire life. And the third delivered prematurely after receiving serial amnion infusions and died at 6 hours of life from pulmonary hypoplasia. The family is appreciative that we were willing to attempt to save their son's life, thankful of the time they had with him, and ultimately the beautiful end-of-life experience they gave him when it became clear that medical interventions were no longer helping. When we invest ourselves in our journeys with our families, we can support them through some of the most difficult times and allow parents to parent and make beautiful memories. It is a true honor and privilege that they let us in during such sacred moments and to be part of their journey. Thank you. You'll have access to all of my references, and now I'll turn it back to Gretel.
Thank you so much, Dr. Cortezzo. We have a few questions that have come in through the Q&A. So the first one was, can you give an example of a phrase that you would say to introduce the palliative care team to a family?
Lots of times, especially if it's a family that I've gotten to know in the NICU over time, the baby has been there for several months, I explain to them that they are a member of the care team that provides an additional layer of support anytime a child has a complex course or the family is navigating complex medical decisions.
Perfect. The next one asked, during prenatal consultations for very premature babies, how much should we emphasize neurodevelopmental outcomes in guiding the parents' decision making?
Honestly, that depends on the family. There are certain families who really want to know the numbers and the details, everything that we pull out from the calculators we use. But many families are deer in headlights and really only hear about the first 5 words that are being said. I think for me, the most important thing in those early prenatal consults around peri-viability is to understand what the family's view of quality of life is, and if that baby survives, if that's potentially in line with that. I also like to remind families and fellows when we're talking about these consultations that we learn a lot of information about babies in those first few hours and days of life that continue to direct those conversations. That just because we continue down one pathway, we don't have to, we can deviate from it if the baby is telling us that they are much sicker than expected.
The next one was, do you have any strategies or specific questions that you ask the family to help you discern when the family is not deriving meaning from the information or not getting it, as we mentioned earlier?
Lots of times you'll almost see that glossed overlook, and I've actually seen in some consults in fetal care settings where they're just so overwhelmed. I've actually had a pregnant individual put their head down on the table and just being very overwhelmed. Lots of times, clues and triggers can be when we quote think that a family is difficult, or they're asking for more treatments when the bedside staff is asking why. That's an opportunity really not to pit the teams against each other, but an opportunity for us to take a step back and learn more about the families. Before I ever get to talking about the decisions that need to be made, whether it's prenatally or postnatally, I spend quite a bit of time just getting to know the family's past experience with medical field complexities, other challenging decisions they've made, and how they approach decisions. I find out, are they type who want to know the big picture or very much the numbers and the details?
It's good advice. Another question was, aside from the list of major anomalies and conditions that we're all pretty familiar with need a palliative care consult, what would be a good rule of thumb that you would say for when a team should consult palliative care in the NICU setting of a chronic patient? I think sometimes, there's like an example of a patient who's been there for months and maybe not getting better, with complex BPD and things like that. What would kind of trigger you to tell a team like, hey, if you're thinking this, then it's probably time to consult palliative care?
I'm a little biased because I think there's absolutely a role for palliative care involvement in any patient in the NICU, and I'm always an advocate and a proponent for the earlier involvement. But if you certainly are at the point where there are decisions around dependence on medical technology, if you're at the point, for example, with the premature baby who is now months old in the NICU, if you're talking about potential tracheostomy involving the palliative care team at that time, if you seem to have uncontrolled symptoms, agitation, if the family is asking lots of questions about what this all means, if you seem to be at a point of contention where what you're seeing at the bedside is very different than what you assume the family perceives, I think those are all good opportunities. But certainly for our chronic BPDers, ideally before the trach discussion is had, but if you envision that they're headed down that pathway, if they're on their second course of DART or corrected near term and are still intubated, those are probably good time points to reassess would it be, if nothing else, for that extra layer of support for the family. This is months that they've now been in the hospital with a very sick child.
And the last question, I think we have time for one more before we run out of time. How do you approach parents who decline any association with palliative care consultants?
I think it's a little bit different for me because, as I said earlier, I don't ask for permission. I treat it just as if I was put in a cardiology consult. I explain to the family why I'm involving them. And every hospital is different. Some of the teams use the word palliative care in their care team, others specifically don't, and term it the supportive care team, because most of the times if adults know about palliative care, it's from their experience with their grandparent or their parent and hospice. I flip the script a bit and I explain about all of the wonderful things that this team, irrespective of what I call it, is going to add to the support and the care for their siblings, for the family, for the comfort of the baby.
Great. Thank you so much. And thank you for your great talk. Thank you for everyone who participated today and who sent in questions. The QR codes for CME credit are here on this slide, but they will also be on our website if anyone needs access to them again. And next month, we are going to dive a little bit deeper into specific communication strategies in palliative care situations with Dr. Henner. And you can also register for that on the website or with these QR codes here. Erin, I think you're muted. We can't hear you.
Sorry, I had double lines of mute. Everyone who registered will get a follow-up email with all of our links and QR codes. So don't worry if you missed it during the talk. We'll get it to you because we have your email. Thank you so much. Thank you, Dr. Cortezzo.
Thank you very much.
Thank you, Dr. Cortezzo. Thanks everyone for joining.